Okay, thank you. All right, so I know you're expecting a break. I know we all want to get out, so I will be quicker, maybe. So, because this was a great talk and kind of covered a lot of things. 5 years ago, if I would have given this talk, I'm not really an expert in VHL, as Dr. Chang said. Well, I'm a neuro-oncologist, but I've taken care of a number of VHL patients during the years, and I've watched in a career that actually started in the early 80s. VHL was a kind of a group of diseases that we used to call phacomatoses, which are diseases that affect the skin and the brain. Neurofibromatosis is the classic phacomatoses, but nobody really knew where to put this group of patients in. And over the years, you've watched this basic science just flourish. And now we stand on the threshold of really finally getting a really interesting and new treatment that seems to be very effective. And so I'm just also going to review how this goes, but from a purely neurological perspective. How do we turn this? How about that? Okay, I have no disclosures. That should tell you that I really don't have much to do here at the VHL and the VHL Alliance. But if anybody wants to recruit me, I'm available. All right, so in the VHL, we don't consider that, VHL, while we've spoken a lot about renal disease, is really most common tumor is the hemangioblastoma. And while it's a benign tumor, it's often the presentation for these patients, and it's really a source of a lot of morbidity and mortality. In fact, in my reading, which was refreshing for today, hemangioblastomas are still purported to be the most common cause of death for patients with VHL, which was surprised me because now it seems like it's much more easy to control. And we've been very good at Stanford with dealing with these patients and preventing this from happening. But anyway, as discussed again and again, it's a multi-organ disease of which the brain is affected. And while most of the diseases are hemangioblastomas, there are also other tumors, and one of them is called the endolymphatic sac tumor, which is there. And that's something that starts very slowly and grows, but it has a lot of implications. It can cause deafness. It's a little different than these other tumors because technically that is not a tumor. It is some other malformation which is associated with VHL, and that's a surgical, sometimes radiation. That's the way you get to it. But most of the neurologic deficits are caused by the hemangioblastomas, and they can occur in up to 80% of patients. They could occur throughout the CNS axis, most commonly, however, an area called the cerebellum. Usually age of presentation is somewhere around 25, and it's rare to present after 65. And as mentioned, most common cause of mortality in these patients. I think that's changing a bit because of really good surgical and radiotherapeutics. This is your hemangioblastoma, where the arrows are pointing. And that's how it looks. Technically, it's a benign tumor, but among all benign tumors, it grows the fastest. It's actually the one that really, even though it's characterized as benign, it really can get people into trouble quickly, and so needs to be monitored. And there are some, patients ask, how do we screen these? And these are the most recent group of recommendations for monitoring the CNS. One is you should have an MRI every 2 years of the brain and spinal cord at least. You should have an MRI before a planned pregnancy. You should have, you don't need MRIs of the brain and spinal cord after age 65 if you have not had a hemangioblastoma. And finally, I don't know why 11 is the cutoff, but about somewhere after in preteen, in the tween 8 years, you should be starting surveillance. Now I'm going to take a different viewpoint, a little different approach from Dr. Srinivasan. This is helpful because this is a complicated pathway, but actually when you break it down, it's very interesting. I wish I had a pointer. So that's the VHL protein, and that was isolated. But the disease, the effector of the disease is this HIF, this hypoxia-inducible factor, which is very important in cancer in general. It's really your sensor for hypoxia. So when the oxygen is low, this gets set up, and this sets up a cascade where you have a lot of effectors. We mentioned VEGF and erythropoietin, and so these. So in when oxygen is normal, in normoxia, you really want to get rid of the HIF because HIF activates a lot of acute stressors. It really puts a lot of stress on the system. So you have to break it down. So it's a very intricate, it's a beautiful system. It's hard really to describe everything that happens, but it's a series of steps which gets it into the proteasome. And the VHL really has nothing to do with the HIF's action, but it has to do with inactivating it. And so by inactivating it, it activates it and chronically activates it, which makes your body think that you're chronically hypoxic. And that's the key to how this generally works. And so basically, if you're in normal oxygen, the HIF is broken down in two series of steps, and then it's removed to the proteasome, what Dr. Srinivasan has talked about, and how to augment that. And if it's blocked, if the VHL, this is in hypoxia, and this first step is very oxygen sensitive. And when the oxygen is high, it gets activated so that it could break down. But when it's low, it gets inactivated and HIF starts to proceed its cascade. And this is the way that we thought about, that people other than me, who are quite an expert, have thought about how to deal with this. And this is the breakdown, and this is the activation. And so trying to address this really has not been possible yet, but maybe in the future. So this is where the belzutifan is really at the effector status. It's blocking here, so it can't get downstream to do that. So VHL-associated tumors, hypoxia generates blood vessel formation, so they are highly angiogenic, and that led initially, before belzutifan, is that there must be a way to stop the angiogenesis. And in renal cancer, that's been a very effective, and agents such as the tyrosine kinase inhibitors, which people have talked about here, have been tested and pretty effective in the kidney cancers. And it's also, they were effective in the retinal lesions, but they're not effective in the mangioblastomas. And so these just summarize some of these treatments and these approaches, and I don't need to do that. My favorite drug, however, is bevacizumab. And so it's the difference between blocking the receptor and blocking the factor that's turning on the receptor. The bevacizumab specifically draws out the VEGF from the system, and this in neuro is important for us. It's collateral benefit. It's extremely good at relieving swelling, which many of these, especially after radiotherapy, is very frequently occurs. And so that in my situation, where either Steve or a radiation therapist will refer me a patient who is having neurological deficits, and the question is what really to treat them with before this year. The question would be whether they would benefit from an anti-VEGF approach. And in fact, anecdotally, I have many cases, but it's also well reported. And so for me, there's no reason for me to use these tyrosine kinase inhibitors in these hemangioblastomas, but there is a role for bevacizumab. Oh, so this just summarizes it, that pazopanib is a very effective against renal cell cancers, not so much against brain, not so good for hemangioblastomas. Many other TKIs have been tried, none have really been effective. And again, my experience, and I maybe not held by everyone, but it's been bevacizumab had been the most effective treatment. So while bevacizumab would be blocking at this level, the question really was, can we block it closer? And that's where the belzutifan came. And my experience with it was different. I wasn't involved in the studies. I was just involved in the output. And really, the people who brought it to my attention were the patients. They thought and tell me about this drug, and I'm saying, yeah, really, they were ahead of the curve, and so they knew all about this, and so I had to study it. And this is actually a series of drugs that comes out of this, and there were many generations of this. And going back to a model, which I put up before, that's working in the axis and it's blocking. And what it does is it folds into, the HIFs have to combine. And so by blocking the HIF2, it prevents their combination and it derails the activation. And it's very effective. And then we have this classic study that was in the New England Journal of Medicine and kind of changed, put this right front and center. And while it was aimed primarily at the renal cell cancers, it also was shown to be very effective, whereas less than 5% would respond to a TKI, over 30% were responding in hemangioblastomas, and thus created a lot of excitement. So yeah, I do use the trade name because that's what the patients told me, Wellerig. It does, and it's binding to the HIF2, and here's the response rates. We talked about the toxicities, and what really maybe earlier, but not certainly, there are concerns about fertility with this drug. These are, this is a very important topic with all patients, with patients with VHL, considering it really hits the symptoms and complications occur really during childbearing years. The drug is a simple drug. Here's kind of the more recent package insert type approach. Again, all of the anemia is a major complication, although I was concerned when I was reading the insert about this hypoxia that occurs, but since we started using it, again, it hasn't been a problem in the real world at all. And patients have been, from my experience, and we're still early, this is a very early kind of transition period when you get a paradigm shifting therapy that comes what we call, it's kind of the post-study era where it gets into the population, doctors can use it. And I'm a big fan of what is now called creative care. You don't always need a study to do, to try to do something. And in fact, that's how many discoveries are made. In fact, that's how it was found that Avastin was good for glioblastomas. Somebody actually had to, there was a black box warning not to use it in brain tumors, but somebody took the chance and it was a great advance. And likewise in this, I think this drug is still finding its niche, where it can be used. And the questions that I'm being asked by my patients is, when should you start it? And I have patients who want to start, they're 21, they want to start it now. And what should they, they have minor symptoms, they have definite VHL. What should they start it? And we have a dialogue that started that is not, I haven't made up my mind yet. I certainly would, I haven't started anyone that early yet. And I'm not sure I would without more information because we have to build up a database. But from the patient's perspective, when I talk to them, I'm open and we're negotiating. And again, so we don't really know when it should be started. I think for right now, the indication is when, for me, for angioblastoma, if it's very symptomatic and Dr. Chang and radiation therapists don't have more to do, don't really know, they're kind of at the end of where they think they can help, I will start. So we have 4 or 5 patients now who are now being treated with this, all well. 2 have responded. I mean, there are, it's an amazing drug for me. I mean, this is in the neurospace since Avastin. This is the most amazing, a very, very effective drug for this particular indication. And since hypoxia is a very important driver in things like glioblastoma, you wonder whether there's applications for drugs like this in those diseases as well. At Stanford, our general approach is the surgeons and the radiation therapists get first. They're the first treaters. But you wonder, I've had patients already ask, I don't really want surgery. Should I start this? And I have to admit, in one patient, it was, her reasons were convincing enough, and she is receiving this, and we are going to see whether that helps or not. And we talked about resistance. So the resistance is the drug, at least what I know in my very naive way, is the drug can't fit in the pocket anymore. There's kind of mutations that are, as you would expect, as the tumors evolve. And that's the reason that you wouldn't start it early. You don't want to start something preemptively. Because of, you don't want to waste your best gun too early. So I know Dr. Srinivasan talked about the future, and there's a lot of ways to deal with that. But for me, and actually, again, this was brought up initially by a patient, and really makes a lot of sense. The future, way in the maybe not as far in the future as it was 3 or 4 years ago, is really when you think about what you really want to do is you really want to take out this VHL mutant gene and you want to put in a normal gene. So you want to do a cut and paste. Sounds easy. And to some it sounds easy. To others, we know it's science fiction still. However, there is a methodology for doing that that's very very promising, although only I follow that literature, and it's really very, while there are diseases, this is a CRISPR kind of approach where you cut and paste, and it's already starting to be used in sickle cell disease. I mean, it's starting to be used, and this is a natural one where you would expect someone to try this, and when you would do it, whether you would do you can even do it technically in the germ cell. Actually, you can do it before you even are an embryo, theoretically. Not quite there yet, but for me, yeah, and that would be very interesting. Then all of us are out of business, right? Okay. So what to take away from this? Angioblastoma is the most common tumor. You probably know that. It's driven by this overactivation of the hypoxia-inducible factor. They are often symptomatic, and until recently, really, radiation and surgery were with what you had, but now we have new medical therapy, of which is finding its place in the niche, in our what I call our quiver. It's a great arrow that we're learning, and as you go to these talks, you'll see more and more about it. And generally, I think that we will have things worked out in a couple of years. Thank you. Thank you.